Early in my training and education, I felt called to serve children with disabilities and special needs. I have a younger brother with cerebral palsy, who, as the oldest sister, I certainly was one of his primary caregivers, being a second mother to him. So it felt very natural, and I understood that it was my calling to find a field in medicine where I could serve children with cerebral palsy. I came as a medical student on a pediatric rotation and stumbled into pediatric rehab clinic with Marshall Taniguchi and fell in love with the field. Then I was able to come back as a resident and spend more time with patients and physicians here. Then I spent 2 full years as a fellow finishing my training here at Gillette, and then had the fortune of staying as a physician for now 10 years. In rehab, we have the privilege of seeing children walking after rhizotomies, walking after orthopedic surgeries. We have the privilege of seeing children learn how to crawl, even though it's a little late, learning how to use communication devices finally and interact with their peers at school. There's many joys and many wins and victories in rehab world. It's a privilege and an honor to work with a family on achieving goals as we step after step work towards the next goal, the next step, and to see a child and a family realize that and achieve that, it's a privilege and a blessing.
Angela Sinner, DO, specializes in pediatric rehabilitation medicine with a special interest in cerebral palsy, spina bifida, neurotrauma, and spasticity management. She received her Doctor of Osteopathic Medicine degree from Des Moines University's College of Osteopathic Medicine in Des Moines, Iowa. She completed a physical medicine and rehabilitation residency at the University of Minnesota Medical School in Minneapolis, and then completed specialty training at Gillette Children's Specialty Healthcare through a fellowship in pediatric rehabilitation medicine. She has made numerous professional presentations on topics including posterior fossa syndrome, autonomic dysfunction in severe traumatic brain injury, and spinal cord injury evaluation. Her most recent research has focused on the acute care of pediatric patients with traumatic brain injuries. Ladies and gentlemen, Dr. Angela Sinner.
Hello, thanks for joining today. I'm Dr. Angela Sinner. I'm a pediatric rehabilitation medicine specialist at Gillette Children's. Today we're going to talk about cerebral palsy, early diagnosis and interventions. We're going to review the literature and recent updates. Thank you. The talk today is going to start by discussing some presentations and definitions of cerebral palsy, so we're all on the same page and understanding. We're going to then talk about early manifestations of cerebral palsy, including screening tools and a timeline for diagnosis, and why early is better. We're also going to talk about evidence regarding early intervention programs in cerebral palsy and what we know. So defining cerebral palsy from the CDC is that it is a group of disorders that affects a person's ability to move and maintain balance and posture. Cerebral palsy is the most common motor disability in childhood. Those of you that work with individuals with cerebral palsy understand that it's heterogeneous. These kids don't all look the same, and they all have different histories from being born premature, term, or post-term. It is a group of permanent disorders that affects the development of movement and posture, causing activity limitation that's non-progressive. The developing brain was affected early, but the injury is non-progressive. And then as we talk more about cerebral palsy, we give it definitions such as motor impairment types and tone abnormalities such as spastic, dystonic, hypotonic, and then we talk about body distribution, quadriplegic, diplegic, hemiplegic. And then we know that there can be a vast array of comorbidities associated with cerebral palsy, from epilepsy, cognitive impairments, chronic pain, musculoskeletal complications, sleep disorders, and vision and hearing impairments. The incidence of cerebral palsy throughout the world is 0.1 to 2.2% of live births. Higher rates in developing countries with decreasing gestational age is occurring. These statistics are from a meta-analysis of 19 studies recently published. And we see that there's that increasing incidence with that younger gestational age, which is illustrated here by the numbers. We're seeing remarkable increased survival rates in the recent decades, and thus seeing more milder cerebral palsy, which can complicate and challenge us in our early diagnosis when presentations are subtle. So early diagnosis, we have 3 tools with the best predictive validity for detecting cerebral palsy at that early age, before 5 months of age even. The neonatal brain MRI is highly sensitive. And then we're also going to talk a bit today about prectal quality assessment of general movements with nice, highly 98% sensitivity. And then we're also going to talk a little bit about what the Hein and the Hammersmith infant neurologic exam is. But the combination of these assessments leads to a more reliable diagnosis along with that highly experienced clinical team. So early diagnosis of cerebral palsy requires motor dysfunction, that we're seeing the general movements are abnormal or there's neurologic abnormalities from some of the testing. And we're also going to be looking for motor development at an atypical age, looking at some of those developmental milestones and when they're occurring. And then what also is required for this early diagnosis is that abnormal brain MRI, along with a clinical history with some of the risks. And this is summarized nicely and outlined. We're going to talk more about this fundamental, pivotal article by Dr. Novak that was published in JAMA Pediatrics in 2017. So high risk of cerebral palsy is also something that Dr. Novak in that article is teaching us that it can be useful when we're approaching a diagnosis of cerebral palsy early, but not quite sure we're landing on it perhaps, that it can be an interim clinical diagnosis. There's not an associated ICD-10 code, but it can help families understand and move along in the discussion of diagnosis perhaps. So if we spend a little more time talking about these general movements, Prechtel's general movement assessment, I want you to understand, if you're not familiar with this test, that spontaneous movement patterns are evident in newborns up to 20 weeks of age after birth, after their term age. The test is performed observing infants while they're awake and calm and not externally stimulated. And it involves watching and monitoring the whole body of the infant, watching for the variability of movements, complexity, fluence, elegance. And so the tester is watching for writhing movements up to 6 to 9 weeks of age. It can be less specific, and these can normalize, thus aren't our most reliable, but these fidgety movements can be present up to 20 weeks gestational age. So testers undergo extensive training, weekends long, days long in many instances. Prechtel's general movement assessment has shown to have better predictor reliability than some of the other general movement tests. So we talk more about Prechtel's specifically. This test is also evolving, where we're moving towards capturing infants even with phone apps so that we can do more remote testing, which will be really helpful. This test is really probably going to explode here in upcoming years as we understand other ways of using it and how to use it. So just a couple examples through pictures here to help illustrate that general movement assessment test. Because it is an effective and helpful test in our early diagnosis. Picture A here is video frames, so you read across like lines in a book. So baby A, these are two different babies. Baby A is a term baby with normal fidgety general movements. There's richer spatial and temporal variation with normal movements here. Baby B is a 28-week preterm baby with abnormal general movements. There's less variability, less variation. The baby looks to hardly move, essentially. This is another pictorial example, more recently published. Similarly, frames of a video are captured here to illustrate. And again, in this example, baby A has more typical general movements characterized by complexity and variation. You can see a lot of variability in this example. Baby B, you can see, has atypical general movements with marked reduction in movement complexity. You can see a lot of the frames are very similar and not variable. They are both 3-month-old infants in these pictures here, and baby B was later diagnosed with spastic diplegic cerebral palsy. Another test we were talking about utilizing for early diagnosis is the Hein, the Hammersmith infant neurologic exam. There are 26 items that assess different aspects of neurologic function, reflecting that gross and fine motor function. It looks at cranial nerves, movements, reflexes, the protective reactions, behaviors, and there's age-dependent items also that reflect that gross and fine motor development. So this test is not paying attention to those spontaneous movements like we were just discussing in the general movement assessment. So the Hein is used most often in infants for 3 to 24 months of age. So the GMAs are for the newborns just past term, where we'll use the Hein more often in the just a little bit older babies. This is an example of part of the Hein assessment scoring sheets. So an examiner would pull this out potentially when they're examining the child and circle and find patterns in the abnormal ranges, and scoring with more abnormality, with more alarm, and more trending towards a diagnosis of abnormal tone, abnormal development, and concern for cerebral palsy. So this is a better look at the Novak article published in JAMA Pediatrics in 2017, looking at how early detection pathways are most reliable. So this is the foundational chart that explains how to early diagnose reliably, as best we can, infants. So the top of the chart, we start with detectable risks in our newborns and infants, and understanding some of the risks that might make us go looking at this chart. So preterm encephalopathies, neurologic risks, parent concerns even, and then some of the developmental delays here. And as we move down the chart, it breaks into the younger babies, less than 5 months corrected age, and over 5 months corrected age. The numbers in front of the tests lower on the chart here correlate with the article outlining some of the reliability and strengths of evidence of each of these. Some of these tests have more strength than other pieces, though they, kind of doing the best we can here. The oranger colors here are a bit less reliable, but again, even though part of the chart has a lot of orange, sort of the best we can right now for diagnosing, the best tools we have. So those younger babies, using Hein and MRI, GMAs more reliably. And then the older babies, again, Hein and MRI. The bottom part of this detection pathway moves on towards continuing to break down, understanding severity of CP, trying to predict severity of CP. So this is a very helpful, very useful tool as we move forward in understanding early diagnosis, and thus move towards talking about early intervention. And I wanted to make sure you're all aware that American Academy of Cerebral Palsy and Developmental Medicine also has adopted this in their care pathway sections, which is free and easily accessible to all. So this is essentially the same diagram to guide those of us caring for these early infants at risk in our understanding for diagnosis and testing. So just so you're aware, that is easily accessible and free online, if it's harder to get to the full article, though the full article is worth it too, certainly. So as we continue to look into the literature on how we understand early diagnosis, this article here, published in 2020, is a review of those infants that are without the perinatal risk factors, so better understanding how to catch those babies too, which is important, obviously, because it can be up to actually half of infants and children diagnosed with cerebral palsy do not have the risk factors. So some of these early cited features from histories, milestones, neuroexam that led to a diagnosis of cerebral palsy include that early handedness, less than a year of age, increased irritability, oral motor abnormalities with feeding problems, and then those abnormal milestones are broken down and explained here. Primitive reflexes could be persisting. There can be asymmetry in how hamstrings and legs are stretching, how hands are opening, or other signs that would indicate asymmetry in muscle tone and movement. Along with, again, they note fisting, scissoring, clonus, and toe walking. So this would be, somewhat more of a guide in maybe for primary care providers or providers that are not trained in general movement assessments and Hein's, other ways to be watching for children that might be at risk of cerebral palsy. And just to better understand what is out in the literature and the movement happening, I'm not going to spend a lot of time here, but even better understanding how we can use updated imaging techniques This is one study looking at a diffusion MRI with term-corrected age to predict cerebral palsy. So just a few infants looked at, but better understanding how this imaging might help us. And these are just some beautiful pictures to kind of help illustrate that. Modern diagnosis of cerebral palsy has to include discussing genetic findings also. So genetic testing as a part of diagnosing cerebral palsy is also important to consider, certainly. Especially when the brain MRI is normal or non-specific. Just understanding that there's other steps to be taken. And then as we get into diagnosing cerebral palsy, we talk about better understanding functional levels. Gross motor function classification system is one widely accepted and understood and reliable tool. There are a few other functional classification systems also to help describe a breakdown in function among children diagnosed with cerebral palsy. For those not familiar, this tool also is broken down by age. So there's more challenges in the real young children under 2 years of age in using this tool or understanding future predictability, but it's very helpful. Lots of descriptions here if you go looking for this tool to help guide and understand future function due to the reliability of this tool. It can help with conversations with parents, families, and providers and caregivers around kind of what to expect, because of course that discussion comes next. So as we talk more about early diagnosis, we need to make sure we understand that brain development, that we're understanding that brain development is occurring early on and evolving. So understanding early diagnosis and the importance of it is an important piece here. Early active movement and intervention are essential because infants who aren't actively using their bodies, using the motor cortex then, can have changes. So understanding the power of that neuroplasticity early on is why we talk about early diagnosis and early intervention. So understanding that the brain is changing in many ways for many months and years really, but catching early on, we hope to have the greatest impact. Besides the impact that cerebral palsy can have to a child's body. So getting ahead of, as best we can, some of those impacts to muscle, bones, and development. So referral to cerebral palsy specific intervention is recommended with that clinical diagnosis of cerebral palsy or the suspicion, the diagnosis of high risk of cerebral palsy as we were discussing. Or really it's recommended with family concern too. So this is a beautiful table illustrating that neuroplasticity and all the changes going on in the brain, the developing brain. This is published in 2021. So we talk a lot about the early brain myelinating and myelination and changes occurring in those early months and beyond. So to orient you to the table here, age in weeks and months and then years is across the bottom. These solid lines indicate active, very active processes. The dotted line are active, though less active processes occurring. So again, we talk a lot about myelination, but there's also apoptosis and pruning going on. Also, there's many processes going on in this developing brain. So this illustrates, the amazing things that those developing brains are doing and the importance of intervening early when it's needed. And again, supporting the strength of parents' perception. So a study recently published found that 86% of parents suspecting that cerebral palsy diagnosis before it's actually made. Delaying the diagnosis is harmful to the parent or caregiver well-being. It's understood. And early diagnosis can help foster acceptance and build confidence in the infant's medical team. So beyond directly the infant themselves, the patient, but the well-being of the family is important in this discussion also. So what is early intervention? Early intervention has been described as the term that describes the services and supports that are available to babies and young children that have developmental delays or disabilities, as well as the supports offered to their family. This can include a wide array of therapies or other services that help those needs of those infants and children. It can really have a significant impact on the child's ability to learn new skills, overcome challenges, and increase their success in school and life. So programs are available in every state and territory. Parents can refer, and services are free. Here in Minnesota, it's called the Help Me Grow program. It's based through school systems and in counties. Cerebral palsy specific early intervention maximizes that neuroplasticity again and minimizes deleterious changes to muscles and bone growth and development. So I want to take a look a bit at some of the early intervention literature. Unfortunately, it's not as strong as we'd hope, but best understanding what we have out there will be helpful. So looking at diagnosis of children with preterm births, these authors note that essential to treatment is the early detection of cerebral palsy to help ensure proper management, and essential to improving outcomes is harnessing that brain plasticity. So they're talking about it in the literature. Again, some of the literature here is disappointing. There's work to do. There's work being done. But these studies here I'm showing illustrate some of the weakness, heterogeneity in treatment interventions, smaller numbers of patients. These are from 2015 to 2017. Important work happening, but more to come, more needed. So this study here looked at some of the diagnosis and rehab services, a scoping review. They looked at many decades of articles, and their conclusion included evidence is sparse. So looking at NICU grads getting referred earlier, but children that aren't within that catchment having more challenges getting in for referrals. This article here nicely outlined implementation of guidelines in a multi-center system to help earlier diagnose and detect cerebral palsy, and they showed nicely that they were able to decrease the diagnosis age for cerebral palsy following implementation of these clinical improvements. So nice outlines for more to be joining in. So now I'm going to move into looking at some more studies that are published around earlier intervention programs, specific programs that were described. This first one here is about the game therapy, game style of intervention. It's a task-specific therapy approach based on active motor learning, family-centered care, parent coaching, and environmental enrichment. Unfortunately, the 30 infants enrolled, there was not a difference seen in Peabody developmental motor scores after enrollment, but perhaps it's a start, perhaps more is needed. It's something that's out there and described, so we're starting here in the literature. Some stronger evidence is coming out of the baby constraint-induced movement theory in infants, and this is one of the studies that is showing some promise as an intervention. This was published in 2018. There were 37 infants that had asymmetric hand use that were enrolled, ages ranging from 3 to 8 months, and they were assigned either baby constraint-induced movement therapy or massage. So they had hands-on, they had therapy, but the control group is the massage group. The constraint-induced movement therapy for these babies included donning a mitten on the stronger hand 30 minutes a day with OT visits weekly. So for this study, they had 6 weeks of therapy, 6 weeks off of therapy, and then 6 weeks back into therapy. At 1 year of age, there were 31 of these children with asymmetric hand use were diagnosed with hemiplegic cerebral palsy. 18 of the babies happened to be in the CIMT group, and 13 were in the baby massage group. So the measures used included the hand assessment for infants, administered at 18 weeks after enrollment, and then also the study found that there was significance between the groups. So the group that had the constraint-induced movement therapy had improvements significantly over the baby massage group. And then at 18-month follow-up, there were a few babies in the massage group excluded so that they could cross over into the constraint-induced group. And the AHA scores, the assisted hand use score, was followed for those babies. We did not have a p-value reported at that age, but there again is some sign of improvement in those infants that received the constraint-induced movement therapy. Another intervention program that's published and shared in 2019 was this EI SMART program for earlier intervention that focused on sensory motor development, attention and regulation, and relationships and therapy support. This is out of the UK. Some of the core components of this program, including actively involving, educating, and empowering parents, supporting that responsive parent-infant relationship, recognizing, supporting, and promoting the infant's self-regulatory behaviors, building infants' next developmental steps to stimulate and elicit active participation, and then modifying the infant's environment to ensure the infant remains challenged, able to participate in a variety of self-initiated, self-produced motor activities in a variety of conditions. So again, this common theme in early intervention programs of the parent support, parent coaching, some of the deficits they're noting in this article too, some of the challenges with responsive communication environment, early language programs often starting at 2 years of age, more work to come. This is another study looking at empowering caregivers to make their own decisions within their family situation, life situation, empowering caregivers to promote that sense of mastery over situations, positively relating to the psychological health of caregivers and may have long-term influences. This study enrolled 43 infants at high risk, unfortunately was underpowered, but again, some common themes in the studies and what's being published and some of the goals here. The COPCA program, Coping with Infants and Caring for Infants with Special Needs, was a family-centered program started in 2011, this is published in 2020. Some goal-oriented coaching for caregivers and parents. In this study, pediatric physical therapists working with families. Themes in this study included supporting the infant in the home, supporting development, giving the infant more time for tasks and development, building caregiver confidence, really building that relationship with the infant. So next part of the talk, I want to come back to another beautiful article by Dr. Novak. So talking about the evidence in interventions for preventing and treating children with cerebral palsy. Dr. Novak was the author of our first big article talking about early diagnosis with the different measures in the graph. Dr. Novak is the lead author in this article too. This are stoplights, traffic lights, published in 2019. So this is a busy diagram, a busy slide, so I just want to orient you a bit. So the size of the circles indicates the strength of the randomized controlled trials, so the strength of the evidence of the measure being discussed. And then as we move up the graph, the strength of the evidence is better. So green, go stoplights, traffic lights, better evidence, whereas we come down to the line, the worth it line, and below red is, stop, don't do it because of the evidence. And again, smaller circles, less evidence, bigger circles, more randomized controlled trials, more evidence. So very helpful, very interesting, lots of information packed in here. If we focus in on the early intervention section, we see a lot of yellow, not a lot of green here. But reviewing some of the articles that we just reviewed, and we mentioned the COPCA, we talked about baby CIMT, constraint-induced movement therapy, which is up higher, almost getting into our green circle territory. And then game we talked about here too is in yellow. So, and smaller circles in this line. So more work to do, but getting started. And then as we continue to talk about early diagnosis and early referrals, looking at where there is strong evidence and where we can make an impact in these children that have some of these findings in parent outcomes and other areas to intervene and influence. And then understanding and illustrating the importance of this topic, if we take a quick look in clinicaltrials.gov, looking at cerebral palsy in infants, looking a year to 18 months ago, this this search would have yielded just about 20 trials, and now repeating it this week yields about 50 trials or more. So more work being done, more work to come. These trials are in different phases of recruitment versus closure, but more to come, and it's important. And even at the federal government levels, this is being attended to and being mentioned in appropriation bills in recent years. So we're making progress, but more work to come. Thanks for joining today. I sure appreciate everybody's participation and ongoing work.